Dr. Milton Wainberg obtained his medical degree from the University of Central Venezuela in 1987, where he was also the valedictorian. He later completed his residency in psychiatry at the Mount Sinai Medical Center in New York, where 1 year later, he completed a fellowship in psychotherapy. At present, he is the professor of clinical psychiatry at Columbia University in New York. Dr. Wainberg is the founder of the American Psychiatric Association's caucus on global mental health psychiatry and served as its chair from 2014 to 2015. He is also a member of the Mental Health Guidelines Committee for the New York State Department of Health's AIDS Institute, where he served as co-chair from 2005 to 2009 and chair from 2010 to 2016. He has received a number of honors and awards, including the Psychiatry Residency Training Award for Clinical Excellence in 1993 at Mount Sinai Medical Center, and the Award for Humanism in Psychiatry in 2010 from the graduating class of Columbia University, their adult psychiatry residency program. Dr. Wainberg has served with many organizations, such as the Society for the Study of Psychiatry and Culture, the Movement for Global Mental Health and American Psychiatric American Psychiatric Association, the New York District Branch, their Commission on AIDS. Dr. Wainberg has participated in a number of research projects as well. A few include substance abuse and HIV or STI risk behaviors in Puerto Rican youth growing up, as well as the Brazilian HIV STI prevention for adolescents, as well as mental health disorders, as well as behavioral activation / armodafinil to treat HIV and AIDS. These words always trip me up. He has a large number of published articles, studies, and contributions to educational and instructional materials. Needless to say, he comes to us with a wealth of knowledge in global mental health. So, ladies and gentlemen, please help me to welcome our speaker, who, thanks to technology, will be presenting all the way from New York via webinar. Dr. Milton Wainberg.
Okay. Can you guys hear me? My goal is to talk a little bit about what's happening nowadays in global mental health, and I'll move on to explain what I'm talking about. Again, next time, I'm hoping that I can be there, if possible. So when we're talking about global mental health, we have to understand the concept of burden of disease. Burden of disease is a combination of two different measures. One is the disability adjusted life years, which actually it's one measure only, which combines two different measures, which is years lived with disability and years of life lost. And as you can see, there are some, basically what the DALIS does is try to understand the impact of diseases in the human being and in society. So we all are born, and if you have a disease that kills you very early, then the years of lost life is much bigger. But if you have a disease that compromises you throughout your life, then the years lived with disability are much more higher. And that's where they have been able to figure out the impact of illnesses in people and society at large. So the burden of disease is combined of the years lost to life and the disability. And combined, you have the burden of disease. The reality is that it is very important to address both of them. We tended to think that it was only lost life as the most important one. And I will talk to you about mental health because it's one of the diseases that has the highest impact in years lived with disability. For example, as you can see, in data from 2015, the years lost to disability for mental and substance use disorders in the whole world, number one is, that's number one. And if you look at the DALIs, which I just explained to you is the combination of disability and life lost, also is the number one. In some countries, it's not as much, but in the world, it's like that. Just to let you know that in Jamaica, it's considered a number 2 burden of disease, second to other non-communicable diseases. So why is that? The reality is that 20% of children globally have a mental problem, and I just explained to you that the sooner a disease starts, the longer it will live with you, the longer the disability will have, which means that half of all chronic mental illnesses start at age 14. So depression and all of the other mental disorders that we're going to talk about today start very young. We tend not to diagnose them because we're not very good at that for multiple reasons that I will talk about. But the reality is 1 in every 4 people in the world has a mental illness. Further, what we know about people with severe mental illness, and I'm talking in this case about people that have schizophrenia, any type of mental illness that includes hallucinations, paranoia, that really disabled people, they happen to be really mistreated by society. They often receive discriminatory care in medical settings. The complaints are frequently discounted. I remember in my residency in psychiatry 400 years ago, that was another joke. I just want to know that you're listening because I cannot see you. There was a patient of mine that had all the symptoms and signs that he needed his appendix removed, and the surgeon came into the room, and the surgeon had the audacity to say that all of the signs that included fever and pain, et cetera, were completely made up by the patient, and of course, did not want to operate on the patient, and the patient, from what it could have been a simple appendicectomy, required massive abdominal surgery to deal with the ruptured appendix, and this is not uncommon. Treatment is less aggressive for diagnosis, even for cardiac arrest. Somehow we don't take care of them the same way. There's overt discrimination for interventions that might hide patient collaboration. There's always the assumption that, for example, psychiatric patients will not be able to follow up, which, by the way, is not the case. There's data that shows that psychiatric patients are able to follow up, sometimes even better, because if they're taking their psychiatric medications, they are already very well trained to take medications. And independent of suicide, the lifespan is shortened by 15 to 25 years. So if you have a severe mental illness, you are destined to die between 15 to 25 years earlier than a person your age who doesn't have. And a physical health worsens the odds of having a mental disorder. So this is the other way around. As you become less young, and you see that you have physical disorders, 1 or 2 or 3 or 4 of them, it increases the likelihood of having a mental disorder. And what we know is that if you look at the prevalence, for example, of the most common mental disorder, which is depression, with physical illness, you have between about half of people could have depression in HIV, in cancer, similar numbers in pulmonary disease also is very high, diabetes is very high, and in tuberculosis is very higher. It's much higher. And this is in comparison to the 10% that it's expected in the general population without a medical illness. So the fact that you have another medical illness makes you more likely to have depression. There's some explanations about that have been done regarding how inflammatory processes are also involved in depression, but I'm not going to talk too much about that. If you want questions at the end about that, I'm happy to talk. So what's global mental health? Global mental health, it's when we talk about a treatment gap. It's when the proportion of people who need mental health care are not receiving it. We then say that there is a treatment gap, and that's what we call global mental health. So it doesn't matter if it's in the middle of New York City in a region where there might be people who are not getting care, or is in Jamaica, or is in Africa. If the number of people who require care are not getting it, we call that a global mental health problem. It's a large worldwide for both severe and common mental disorders. Worse in low and middle income countries. About 75% of people with mental disorders are not in care. And sometimes the treatment, if it's provided, is below minimum standards. And there's little money allocated for these issues. So the World Health Organization has determined that you need an ideal number of 45 mental health specialists per 100,000 people, which is the number that you have here in the ideal. The reality is that worldwide, there's 1 per 2 million. So it is truly impossible to be able to determine. And I don't have the Jamaica number, but I can tell you that Switzerland is the country that gets closer to the 45. The US is not that good. And I'm going to talk a little bit about Mozambique, which is a country where I've been working the last few years, that their number is 0.052 for 100,000. So as you can tell, there's very little availability of mental health providers. So we had already talked about this. So when provided is minimum, and one huge issue is stigma. What we know is that we never think about psychiatric patients, even though I'm going to say, without looking at any of you and without any judgment, because I'm a psychiatrist, so I don't judge you and expect that there's 1 of every 4 of you that has a mental illness as we're talking and may not be either sharing it, talking about it, and I'm not expecting that you'll get up to say I have it, but it's very likely that some of you do and are not getting the proper care. And this is one of the issues. Here you have psychiatrists, psychologists, nurses, and social workers. And this is according to low income, middle, high, and high income countries. And this is the proportion that you have. It's very low. And the issue is connected to the monies that are allocated for people to get the care. So whereas in low income countries it's 20 cents of a dollar, it's $44 in high income countries. And this is the percentage of the country budget for healthcare. Mental health can go anywhere from 0.5% to 5%. And remember that I was just telling you that mental disorders are considered, if not number 1, number 2 most burdened diseases worldwide. And here we're providing this amount of services for them. So resources needed, and the sad part is that resources needed per capita per year in low-income countries, it's only $2 more per person, per capita. And in high-income countries, because of the value of resources, the cost of resources, it's only $3 or $4 more. And the WHO has very clearly come out saying that each dollar invested in easily scalable mental health treatments and services for depression and anxiety returns about $4. I don't know any of you, if somebody comes to you and says, if you invest $1, I will give you $4 back, I can certify that you would be crazy not to invest on that. That was another joke. The reality is that we know this, and yet countries are not investing. That would mean that if you invest in Jamaica to provide proper mental health care for adolescents and young adults, what would happen is that they would be able to provide to the country 4 times what they're providing right now by working, by education, et cetera, et cetera. So even in the US, which we're supposed to be the mecca of wonderfulness, 67% of people with behavioral and mental disorders do not get the treatment they require. Between 30 and 50% of the referrals from primary care to mental health clinics don't make the first appointment. So we're very bad at making sure that people get the care once referred. And 2/3 of primary care physicians in a study that was done with 6,600 of them reported not being able to access outpatient mental health settings for patients, and the shortages in providers, the barriers in plans make it a barrier for them to get the care taken care of. So what we know is that we're very bad in systems to take care of these. The challenges all over the world are the resources, their limitations and ability of trained personnel and financial resources. Even resource-rich settings have produced evidence demonstrating that prevention, intervention, as well as psychological and psychopharmacological treatments are available and effective. So we've done a fantastic job at creating medications. Yes, I'm talking to pharmacists, so you know about that, and even psychological interventions. Yet they are not being disseminated and implemented because, number one, they are done by specialists. And if we just spoke that you have one mental health specialist for 2 million people, that means that these interventions are not getting out there. So How do you attack that? One word that has come up in the last decade is task shifting or task sharing, which means that you reassign specific mental health assessment and treatments to be done by non-mental health specialists. That can be either community health workers and teachers, can also be primary care providers and nurses. The reality is that there's a plethora of research that has shown that most people well-trained are able to do this without having to have a specific mental health specialty. They should be trained and supervised by mental health specialists, but the provision of care can be task shifted to people with lower trainings. Another of the solutions that has been provided is the idea of doing something that is called step care, that you match the needs according to what you provide according to the needs. So if I'm depressed, there's no need for me to see the one psychiatrist that works in town. I should be able to be seen by somebody that is trained to treat depression, and only if it gets complicated, I should see the psychiatrist. And there's also the ability of doing self-help interventions. There are multiple manuals of self-help tested, and I'm talking evidence. I'm not talking, made at home manuals and how to do this. So we have the ability to increase these. However, very few things are being done at the same time. So I'm going to give you one example of a country that I admire in spite of their lack of resources. So Mozambique, as you see, is in Africa, here in the orange. It has 25 million people. It's 60% rural. It is considered the 7th poorest country in the world. They have an HIV rate about 20%, and TB is also very high. They have 13 psychiatrists, 78 psychologists, no PhDs. Actually, one of the work that we're doing is that we're helping create PhDs. And this is important because in countries like Mozambique and the Africa region, if you don't have a PhD, you cannot be a researcher. They don't respect your voice. The budget is less than 1%. However, supposedly, as per the government, everybody has free access to mental health services. So this very, very poor country, the 7th poorest in the world, as the HIV epidemic was taking place in the 80s and 90s, and medications were becoming available as of the mid-90s, and the country realized that they also didn't have physicians, what they did is that they trained nurses and what they call medicine technicians in rural areas to provide basic HIV care. So the 3 psychiatrists in the country at that time were very smart, and they said, if you can do this for HIV, we're going to do this for mental health. So they created what they call Psychiatric Technicians. It's the first country to develop a task shifting policy. And as you can see, this is, for some reason, the years did not come by. This is 1996. This is 3 years later, 10 years later, and this is currently, where every area of the country has at least 1 psychiatric technician per district, which is not that many. It's 275 for 25 million. So, but it's in a much better place than it was 10, 15 years ago because of the task shifting that they created. And the work that we're about to do there is a new study that it's going to be set up in 3 provinces of Mozambique, where they would be basically touching 40,000 people, where people will have either usual care, where they receive the care by psychiatric technicians at the district level, which is sort of like cities. A second pathway where all the care will take care in clinics in rural areas. So the same nurses and medicine technicians that are providing HIV basic care will be trained to provide medications and psychotherapies for mental disorders. And a third one that it's more step care model, where, so this is task shifting, and this is step care and task shifting, where both the community health workers in the community, rural communities, will providing part of the care, psychotherapy and groups, and also some of it will be done in clinics by the clinic providers, the nurses and the medicine technicians. What we have done here at Columbia, we have acquired from the National Institute of Mental Health training money to provide PhDs and MDs from the US to work in global mental health. So far we're working in these specific countries. So we have people working in Puerto Rico, in Peru, in Colombia, in Brazil, in Mozambique, in Uganda, in Nepal, in Mongolia. And one of the persons that she's actually listening is Karen Johnson, who's going to be working in New York City, but I'm certainly expecting that with time, she will go back to her Jamaican roots to work with whoever you can connect her with to do mental health care in Jamaica. So I did not just want to talk about these. I thought that it would be a good idea to go over a few of the most common mental disorders. So I will track what we know about HIV and mental health disorders. And as you can see, the prevalence of mental health related problems in HIV care settings is really high. You have depression, alcohol, anxiety, cognitive disorders, pain, and insomnia. And I'm going to talk today about the two first. So let me give you a case, and this is going to be complicated because I cannot see you and ask you to raise your hands. A 47-year-old man with AIDS, schizophrenia, and diabetes presents with worsening hallucinations. The first thing you should do is ask him when he stopped his psychiatric medication. 2, refer him to an on-site psychiatrist for the evaluation. 3, check his blood sugar. And 4, assess for medication-drug interactions. So I want you to applaud as I say each number. Who thinks is number 1? Applaud. Okay. Who thinks is number 2? Refer him to an on-site psychiatrist. Who thinks is number 3? To check his blood sugar. And who thinks is number 4? Assess medication-drug interactions. Well, I cannot tell who applauded, but boy, you had a bigger number 3, and you're absolutely correct. Because the blood sugar is the issue here. He can have a delirium because of blood sugar problems, and actually it was 600. His worsening hallucinations cleared following the reduction of the blood sugar. So going back, assume that the person stopped medications, not a good assumption. To refer him to see the psychiatrist, which may take 3 weeks to happen. In the meantime, the person will die from a delirium because of because of sugar problems. And drug interactions at this point is not something. The only reason it would have been if, for example, as you pharmacists know very well, if by a chance this person would have been prescribed a new medication 1 or 2 days before. Otherwise, that's not even the issue. So, I just described to you that delirium or any change in mental status requires an evaluation in anybody, and especially in people with HIV. You always look for underlying biological causes to rule out the delirium or any other mental status changes. So first, any medications that the person is taking, substances that he may be taking, non-HIV medical problems, like in this case was the blood sugar problems, or HIV-related illnesses like central nervous system lesions, infections, non-central nervous system medical problems. For example, hypogonadism, which is low testosterone, is common both in people with HIV, by the way, both in men and in women. I don't know, applaud if you knew that women have testosterone. So let me tell you, when you use your testosterone, we have names for you, which is how you behave just like us. So we somehow call you names when you behave like us, but we don't call ourselves that way. I hope you're understanding what I'm saying, because I'm not allowed to use bad words when I'm being recorded. So whenever a man says to you, you're being such and such, you just have to say, honey, your testosterone makes you like that all day long. I only have it a few times during the day. I hope that there are a few men in the audience that are turning a little red. Okay. So after you rule out all those number 1, 2, 3, and 4, then you could say actually it's either or. You can have a psychiatric disorder, or you also can have a cognitive disorder. So people with HIV have cognitive issues. They're not the only ones, of course, but they're most of the time overlooked. And we only look at them when people are completely demented, which is not the right time to do it. And I'm saying that, and it's the last thing that I'm going to say about this, because addressing this is so important that you need to treat with antiretrovirals. And if the antiretrovirals are not helping with these problems, you need to add other medications. So you pharmacists who work in this area, hopefully will talk to HIV providers and primary care providers about this. So the issues with depression and alcohol and HIV are as follows. Number 1, the increased morbidity and mortality, failure to initiate antiretroviral treatment, failure to adhere antiretroviral treatment once initiated. There's a slower virologic suppression, meaning that it prevents the decrease of the virus in the body. There's a faster virologic failure, especially with alcohol and substance abuse, which means the person doesn't respond to improving the viral load in HIV, but it would be decreasing it, and increase HIV-related risk behaviors that people then may be prone to infect others, which is an issue, of course. Depression is present in about 30 to 50% of people with HIV, and the problem is that if you don't treat it, you have the problems that I just talked about. If you treat it, people do just like the others. Major depression is the most common form. It may have some psychotic features. Dysthymia is when the symptoms are not as severe, but they last for more than 2 years. Whereas major depression, 1 or 2 weeks is enough to do the diagnosis. And bipolar disorder is part of a cyclical mood of disorder when you have some high moments and some low moments. It's important to figure it out, because if you treat with an antidepressant somebody who actually have bipolar disorder, they can become more manic. The primary focus of what I'm going to talk about is major depression. And here are the symptoms: depressed mood, loss of interest, guilt, worthlessness, hopelessness, suicidal ideation, and there's some of them that are somatic, which is appetite and weight loss, sleep disturbance, agitation, retardation, fatigue, and loss of concentration. Evidence is emerging for a bidirectional relationship between depression and inflammation. So we know that some of these things that, for example, people with HIV may have more depression, perhaps because of the inflammatory processes. And as you can tell, these somatic issues can be present in people with HIV and can confuse the picture. Is it depression or not? Our recommendation is that if you have some of these, you should include that they have some of these too in making a determination of the diagnosis of depression. And this is the outcome of not doing the right thing. So there were 2 studies that are massive. This is 765 people with HIV, women, in 4 sites in the US that were followed for 7 years. The mortality predictors were chronic depression, the CD4 count, which you may know is the white count that we know to determine the immune system. The lower the CD4, the worse is the illness. And antiretroviral treatment duration, how long they were in treatment, and age. After they adjusted for all other variables, women with chronic depressive symptoms were twice as likely to die as women with limited or no depressive symptoms, which means to us, we need to treat the depression, otherwise we're letting them die sooner. And the issue is that we have a solution. It's not something that we cannot treat. And there have been multiple other repeated studies that have shown the same. And this is another one in Tanzania, which is with pregnant women, followed for 6 to 8 years without antiretroviral treatment. This is, we don't do this anymore. Now we have antiretroviral available. So this is the clinical stages for HIV. 31% died during follow-up, which is astonishing, right? 31%. Depression was associated with a 60% increase in risk of progressing to the worst clinical stages, which are 3 and 4. Remember, they started with 1 and 2, and they progressed to 3 and 4, and greater than a 2-fold increase of risk of death. So their likelihood of dying was more than double, and only because we were not treating the depression. So it is a human right to treat mental disorders, because otherwise you're making sure that people die earlier, and by the way, suffer much more throughout their lives. The good thing is that it's very easy to screen. They're fantastic screenings. There are 2 to 9 questions. They're available online for free, so no excuse. It's already translated into multiple languages, well-studied in general medical population. Very easy to administer or even self-administer for people that know how to read and write. Can be used to screen, make diagnosis, and follow up people. So there's no excuse. So the PHQ-2, which is 2 questions, little interest or pleasure in doing things, feeling down, depressed, or hopeless. If any of those is positive, you move on to do the rest of the questions. If they're negative, you don't. So it takes 2 minutes to assess this. There's no explanation for not doing it. So if the score is 3 or more, major depression is likely. So you have several days, 2 or more than half days. Screen further using the PHQ-9, which I will show to you in a minute. It can also be used as a yes or no. And if you have yes to either question, you screen for the PHQ-9. So if it's yes for this and yes for that, you move on to the next one. And the PHQ-9 has the same 2 first questions, right? Because you always start with the same 2 questions. And then it has troubles with sleep, feeling tired or low energy, poor appetite or overeating. These 6 should have not been here. Feeling bad about yourself, low self-esteem, trouble concentrating, moving or speaking so slowly that other people could have noticed, or the opposite, you're very restless and agitated, and suicidal thoughts. This can allow you to do a diagnosis and to follow up people. And some of you visit providers, please let them know and show them links where you can find them. Evaluate for contributing biological factors. As I said at the beginning, remember that graph where I showed you all the things that you need to rule out? And you need to rule out a bipolar disorder. Also ask about past family history for the bipolar disorder. Somebody whose relative had bipolar disorder is more likely to perhaps have bipolar. They can also just have depression, but it keeps the provider more aware of the reality. And in the past year, while not high or intoxicated, did you ever feel extremely energetic or irritable and more talkative than usual? This points to bipolar disorder and not depression. And it's important because you don't want to treat just with an antidepressant. You may need to treat with a mood stabilizer that you guys probably know about because they're lithium and other anticonvulsant medication. And there are many other treatments. So treatments we have SSRIs, SNRIs that US pharmacists, I hope you know. You have tricyclics, there are other antidepressants, atypical antipsychotic mood stabilizers for bipolar depression. In the US, they're starting to do brain stimulation treatments that can include ECT, by the way. It's not as bad as we used to think about it because we were not doing it the right way, but there are people who do not respond with any of these that may require ECT. Light therapy for seasonal depression. It's simply 20 minutes every morning of light therapy. And for those in HIV care, should avoid St. George's Wort. Antidepressants among adolescents is considered to increase risk of suicide, but just by looking at, assessing people, one can prevent anything happening. And there's these guidelines that you're, feel free to look at them, that we tend to update them every so often. And also in the website, hivguidelines.org, we have a full section on mental health and substance abuse with multiple documents that can help you learn more about this. In general, SSRIs are well tolerated, are safe, lower rates of drug discontinuation. Drug interactions need to be considered with fluoxetine and paroxetine. And avoid paroxetine in pregnancy because it's a category D. Others can be used. Assess for testosterone deficiency, remember what I was just telling you about? That may contribute to depressive symptoms, and then you treat with testosterone, not with an antidepressant. Antipsychotics for people who have psychotic symptoms within depression can be used. Older neuroleptics, they have very high extrapyramidal side effects, so we tend not to use them. The new atypical one are easier to use, but they do have metabolic complications, so people have issues of metabolic issues in regards with obesity and cholesterol. When medically when HIV medically will start low and go slow because people tend to respond, people with HIV tend to respond faster to lower doses. And for mood stabilizers, avoid carbamazepine because it lowers the antiretroviral levels. And avoid lithium when people already have neuropathy because it can increase neuropathy. Neuropathy is very common in people with HIV. There are other therapies. I'm not gonna, what we know is that issues of treatment adherence, just treating the depression alone is not enough. You need to make sure that people are adhering and covering that to make sure that they're adhering to antiretroviral treatment. In psychotherapies, I'm not going to spend too much time on this because I'm assuming the pharmacists don't provide psychotherapies, but there are multiple studies that have shown that interpersonal therapy and cognitive behavioral therapy can be used to treat depression and anxiety and trauma and uncomplicated trauma, and sometimes patients prefer them because it means not taking another medication. You can combine those, the medication and the therapies. And treatments that appear to be ineffective include non-specific coping interventions and herbal vitamin supplements. So what happens is that a lot of people think that you're helping others by providing them support. That has not been tested. So it's very important to make sure that people use interventions that have been tested. So the treatment, a large study in the US has given a lot of information about major depression, that it is valuable for prescribers in primary and HIV care to know how to use several antidepressants and to be willing to switch patients from one to another, because sometimes people respond to one or don't, but then respond to another. And they're so told, it's so easy to change them that it should not be a problem. And this is based on a study that they use a method of allowing providers to start with one and then move to another if the person would not respond. Some models of treating depression in primary care, why can't they do it alone? There aren't enough of them. Even if psychiatrists and other mental health specialists did nothing else, depression is too common to be treated just by them. So, and remember Mozambique, right? 13 psychiatrists and 75 psychologists, that's, just imagine. They probably don't sleep ever if they would have to be the ones prescribing these medications. So they can be easily prescribed by multiple providers. And most patients don't want to see a mental health specialist. It's less stigmatizing for your primary care provider to give you a psychiatric medication when there's a simple problem like depression than having to go to a psychiatrist. Obviously, if there are complications or more specialty care is needed, it's a good idea to visit them or consult with them. Just a few words about alcohol and substance use in HIV. Even before I go to that, there's data that shows that 50% lifetime comorbidity of substance use and other mental disorders, which means half of the people that have an alcohol or drug problem end up having another mental disorder. And half of the people with a mental disorder that it's not substance abuse end up having a substance use disorder. So the likelihood of the two of them being combined is very high. There are common underlying genetic environmental vulnerabilities for both type of disorder. You know, depression, people with depression, we know that there are genes that make you have family impact. The same thing with substance use. Mental, and they can be co-located in the same family. Mental illness leads to self-medication with substances. So sometimes people use substances to treat themselves, which should not be the way to do it. Substance use and withdrawal leads to symptoms of mental illness, and evidence exists that for each of these explanations. So they're very common, and they should both be treated. And again, it's so simple to assess. 3 questions. How often do you have a drink? How many standard drinks containing alcohol on a particular day? And how often you have 6 or more drinks? And by the way, this is one place where women, I'm sorry, you are again being mistreated by society. We believe that we know that the hazardous drinking of more than 4 drinks a day is for women and more than 5 is for men. And I don't mean that you can have that every day, but when measuring in any day. Somehow nature was a little bit mean to you in the amount of alcohol that you can have. That was another joke, people. Are you there? No. So women, are you aware that you always cannot have as many drinks as men? Isn't that pitiful? Okay. So again, these are questionnaires that are available online. It's easy to find. The Cage is also another one that can be used, which measures being able to cut down, people being annoyed by you, feeling guilty, and that you need a morning something to have an eye opener. And again, more than 2 is suggestive of a problem, and here's the guidelines that I was telling you before that you can look at. And I hope that you will have access to the slides. There's also this instrument for drug use. I'm not gonna go over it, but it's the DAST 10 that again is very easy to administer. And what we know about substance abuse is that people have different approaches in looking at how to take care of it. The old school was, you're so bad because you're drinking and you should stop drinking, and somehow we think that people will change because of that. But the reality is that Prochaska and De Clemente have conceptualized what we know is that people are contemplating stopping. They're in pre-contemplation, meaning they're not even thinking about it. They're contemplating stopping. They're preparing for it. They're in action. When they're more than 6 months, stop. It's maintenance, but there's always the possibility of relapse. And this is important because people need to be given support according to where they are. So it's important for clinicians to help identify conflicts between the current behavior and the past behaviors. With regards to substance, the clinician has to reflect on the discordance. So in motivational interviewing, which is the therapy that I'm talking about, it is very important for people to look themselves at what they're doing to themselves. It is very different if I tell you, don't you see that you're destroying your life, that you're destroying your marriage, that you're destroying your work? You're going to defend yourself. So the goal here is for the provider to ask questions, so the person is the one who talks about these. And it gets reflected in a specific way to make sure that the patient thinks about it and not feels guilty about it. It's important to ask open-ended questions so you get a story, be empathic, acknowledge the strength. And people sometimes have already stopped before and they feel that they will not be able to do it, but that's quite the opposite. The fact that they were able to do it once before gives them strength to do it again, but just identify what brings them back to do it. The reality is that our attitudes in talking to people can really make people not listen to us. And by the way, this is not just with substance abuse, it's in life. I know best what the patient needs, yeah, really, because I'm 24/7 with him or her. It's my role to advise, and they can do whatever they want. And if they don't do it, they're treatment resistant. If not, they're manipulating me, or they don't want help. Somehow, whenever I'm not effective, I always blame the patient. And this is very common in medicine. And sometimes they even feel that the patient doesn't deserve it. The reality is that as a provider, there's a public health need to not think of you versus me, but together, and what do you want help with? Because maybe you have the answer better than I, because you live with you 24/7. I care about your opinion of my recommendations. It's okay for us to disagree. We don't need to agree. So there's not, I always tell providers, you don't need to be right, because if you're right, then you're wrong. It doesn't matter if you're right and the patient in front of you disagrees with you. And people do things to feel better, so it's important to understand that this is not just that they're mean or they're not good people. The perception of the reality is critical. There has to be adequate access to where to get care, and we need to feel very aware of our own feelings of how we deal with people who use substances to be able to help them better. So just to end, it is important to think of what are models of when you have providers available. Sometimes you do referrals in a consultative model. So the mental health clinician who is often off-site sees patients alone or to varying degrees reports back to primary care providers. Sometimes you can have the availability of co-located models. where mental health clinicians see patients adjacent, so in the same, a clinic that is next to your clinic or a provider that is right next to you. And obviously the integrated care is the best, is when the access is free between both and there's good communication. Any questions?
One question.
Only one? Wow.
So far.
Tell me.
Hi, good morning. It's Dr. Wainberg.
Dr. Wainberg, Milton Wainberg.
Okay, great. So my name is Christina, and I'm one of the Jamaican pharmacists. When you mentioned that 1 in 4 persons have a mental illness, the colleagues around my table seem shocked. Mm-hmm. But a lot of persons really are more familiar with things like schizophrenia, bipolar. But could you speak a little to other mental illnesses, particularly like cluster B, borderline, antisocial, histrionic, and the other ones that are not as familiar to us here?
Okay, so I am so glad that I was not there and you're providing me the picture of what I said. So unfortunately, the reality is that, yes, the percentages of schizophrenia and bipolar disorder are much lower, are not 1 in 4. It's actually considered that 1% of the population has schizophrenia, a little bit more than that has bipolar. When we talk about combined all of mental disorders, and the most common, by the way, are depression, anxiety, and substance abuse. When you combine all of them, you have 1 in 4. So the cluster B that you just mentioned are more personality disorders that are frequent, but that's not exactly what we're talking about for the 1 in 4. Personalities are very hard to assess, and you need very extensive questionnaires to be able to assess personality disorders. So the global data doesn't evaluate as much personality disorders. In some countries they do. And it's not what we're talking about necessarily as what increases the burden. What considers to increase the burden of diseases are depression, anxiety, and substance abuse. However, people with personality disorders can have very complicated lives. There are multiple disorders. There's some of them that keep you at home, very isolated. There's some of them that make you look that you are a little bit different and people avoid you. There's some of them that most of the time are connected to traumatic events in childhood or other traumatic events where people have less respect for those that are the most important people in their lives, because unfortunately they were traumatic towards them, and therefore interferes with the ability of people to trust others and can interact in a way that makes it complicated. There's also post-traumatic stress disorder that I haven't mentioned. So in some countries where you have had major either natural disasters or man-made disasters, genocides, Holocaust, civil wars, or going to work can increase the likelihood of people having post-traumatic stress disorder. When people are exposed to major events, 1 in every 4 gets either depression, anxiety, or PTSD. So the problem is that our disorders are very stigmatized. So people don't walk around saying, I'm depressed, and tell others. They hope that it gets better. They do other activities that can be helpful to them, but the rates are very high. I'm not gonna screen all of you because then you will not like me anymore, but assuming that now you like me. But it is much more common than we think, but we just don't talk about it. It's easier not to talk about it because it's stigmatized. I can tell you that in many communities, having a member of the family having a mental illness could impact the ability of the whole family in getting married. So people don't talk about it. So I hope that I answered your question.
Yes, doctor, could you address the connection between cannabis use and psychiatric disorders?
Ooh, that's a big question, and thank you so much. So, you know that United States is moving towards opening cannabis much more, and in some states it's freer. I think it's a disservice to the public health system. There are people who can do it in a regular basis and not have any psychiatric symptoms. Unfortunately, number one, there's some people who respond terribly, and I'm not going to ask people in the audience to get up if they have used marijuana and have felt depressed or seen things that were not there. I am sure that some of you are in the audience like that. I can share with you that the couple of times that I had cannabis, I was crying like a Magdalena for hours, and I asked my friends, how do you do these? It's like, why? So I'm not asking you to share, and because I don't live in Jamaica, I can say these. I don't know if I would be there, I would say, but probably I will. As you know, I say what I think. The problem is that the brain is a malleable organ. We know that we can change the brain. So let me give you an example. If you treat schizophrenia early, you prevent the illness of getting worse, which means that the brain can be modified for better when you have an illness. With cannabis, it's the opposite. You can train the brain for worsening effects, for lethargy. I have had multiple patients that, yes, they're functioning and they're doing great, quote unquote. And then they realize that if they stop the marijuana, they can function better in life, do better at their jobs, be more active and participate in the family. Some of you may disagree with me, especially those of you who use it, ha ha ha. However, I am not suggesting it to be, the concern is to go from illegal to pan use, to generalizing it, and especially adolescents and young adults, because once you try one, we know that starting cigarettes implies then moving towards marijuana, that then moves it to cocaine and other recreational and natural recreational drugs. So the cascade of marijuana increases the likelihood of going to other drugs. I hope that I summarized what you were asking me.
Thank you, Doctor, for your presentation. I just wanted to ask you to zero in more on the pharmacist role as it relates to not only the pharmacotherapy of mental illnesses, our contribution to that, but in terms of the screening process, because you've allowed us to see some screening tools that can be accessed through the internet. Is it that as pharmacists we can direct persons to these tools and ask them to maybe look at how best they'd like to deal with their issues depending on how they answer these tools? Are there other things that we can do as pharmacists in Jamaica to make sure that our mentally ill persons are being cared for?
I love your question. Thank you so much. I think that I'm so happy you brought it up. I'm so stupid that I didn't talk about it, but hey, that's why you're there, to make me talk about what needs to be said. Number one, the fact that you guys are bringing this topic is amazing. It's not necessarily what pharmaceuticals and pharmacists tend to think about. I totally agree with you, especially if you are within a company that distributes psychiatric medication. By all means, make sure that your providers know about these measures. If you happen to be a pharmacist not connected to pharmaceutical companies, it is very important for you to, I don't know how it is, the pharmacist role in Jamaica. I can tell you in Venezuela, where I'm from originally, the pharmacist sometimes is the one who prescribes medication. I'm not quite sure that that's the right thing to do. So I'm not suggesting that you do that. You need to follow what are the rules of your country. But it would also stimulate patients that come to you to decrease the stigma and even talk to, if a patient comes to you and tells you something, I would even feel comfortable asking that patient, you seem to be in a lot of pain. Your doctor, I'm sure will be able to help you. Do you want me to give him a call or give her a call? So I can let them know that you need to be seen. Because sometimes it's hard for patients to say, I am depressed and I want to be seen, and they're concerned that their medical providers are not going to be responding properly. So there are multiple interconnections that you can do with patients, with providers, to bring them these tools and make them aware of them and how simple they are, and to sort of understand that this is a huge issue. People with mental disorders, and I'm not just talking severe mental disorders, don't function as well, don't enjoy life as well. And it is so simple to treat it. We're not talking surgery. We're talking either a therapy or a medication or both, and life can get much better. So there's very few negatives in trying to do this. And if we start, working all together in understanding this, the stigma issues are going to decrease. That's something that we learned dramatically in the HIV epidemic. HIV is one of the most stigmatizing illnesses in the world. And imagine if we're going to add to you that you have a mental disorder. Whoa, double whammy. The reality is that once we started working with providers and patients, people realized that if you don't do what you need to do, then you are not adhering to medication, you're not enjoying your life, you're not functioning as well. So as the person who did not win the presidency here in the US says, it takes a village. It takes for all of us to truly think how to improve the life of all of us. So whatever you feel you need to do, read more about it and do it. And you should have more trainings like these and workshops like these where you can not only listen from this Venezuelan bald guy in the US, but to perhaps work on how to address this issue in a more specific way, with workshops, with comments to make, how to approach your providers, how to approach patients that come to you if you work in a pharmacy, et cetera, et cetera. Thank you for the question. It's beautiful.
Professor Wainberg, really informative presentation. Thank you for that. As you know, in the Jamaican setting, because we're a developing country, we can't allocate a lot of money to mental health in the budget. As a result, in recent times, we have shifted from an institutionalized approach to a more community approach where the patients are sent back to reintegrate with their communities. Now, this in and of itself, it has posed some challenges because we have had incidents where these patients are actually hurt by others. I know that you have done a lot of research in this sort of setting. So what do you think would be a balanced framework for the Jamaican setting?
Well, it's a huge question, and we had the same problem in the US. Hold on a second. My little dog wants to leave the room, doesn't like your question, so wants to leave the room. 1 second. I'm sorry about that, but my little dog was accompanying me, and he said, I've had enough. That was a joke, people. Okay. So, we in the US did a terrible job with that. One day we decided to close hospitals, and we sent people to the community without preparing the community to deal with it. I can tell you many years ago I had these, and it gets even worse. I remember many years ago, because when I was working full-time as an HIV psychiatrist, there was an appointment on a new patient at 10 a.m. The person didn't show, and in the afternoon I was doing consultation in the hospital for people who were hospitalized and needed psychiatric care in the HIV ward. And the nurse from the outpatient setting called me and says, Milton, your 10 a.m. just showed up. And I said, it's 2 p.m. And she says to me, Milton, just come down and you'll see what we're talking about. So this was mid-November, freezing winter. The guy showed up without shoes, without socks, with a black garbage bag as his clothing, coming for a psychiatric follow-up after having been discharged from a jail. And what this tells you is that the system is so poorly organized that instead of making sure that this guy has a place where to be, has an appointment that I know who he is in advance, which is so simple, because the systems can be connected, he was completely disregarded. And of course, I went downstairs and took care of him and figured out what to do with him. So we have not trained people in the community to do the right job. It is very easy to train, but somebody has to do it. So the most important thing here is, as we close hospitals appropriately, because people should not be in hospitals just because they have a psychiatric disorder. They can be reintegrated to the community, but they needs to be done using, there's several interventions. There's the ACT team, there's the critical time intervention. There are ways to train communities, and not only the providers, but the relatives and people who are the main stakeholders, churches, community activists. This is a job and it's not that complicated. It just sounds big, but we just need to train people so people know what to do. So the solution is not just close hospitals and send people. It's send people to places where we have provided the proper training. And remember, with task shifting that I explained today, you don't need everybody to be a psychologist or a psychiatrist. They need to be supervised. But there needs to be an infrastructure that provides the proper care that people need.
Doctor, if you would allow me, because you talk about training for persons in the community, and according to, when I saw the Mozambique slide, it was as a result of these technicians that were being trained and the increased amount in the different areas that you had a better mental health overall approach to that country. So what are some of the qualifications, I should ask, of these psychology technicians that I see you have on the slide? And what are some of the training that it will involve? Because if Jamaica can actually take on that community approach but being trained, I think it'd be better for us.
I think that Mozambique is a brilliant country. So I was not involved in doing that. They did this. This is people who finish high school, then get 2.5 years of training in mental disorders. The last year is fully clinical, where they're supervised by another psychiatric technician. They work together with another psychiatric technician, and they're supervised by a mental health specialist before they're being, so they have about 4 different cities in the country where they provide this training. It's a source of income because people then work for the Ministry of Health, and they have 2.5 years of training in psychiatric illness. They prescribe medication and they provide psychotherapies. What we're doing now, because that is still, it means money. So I can tell you that probably costs about, for them, about $60,000 a year, which is not that much if you think about it when you're training, 100 people. Hold on a second, people did not close the door. Oh, no, it's closed, yes. So they're doing it in 2.5 years. What we're doing, and I'm going to bring back the slide. I don't know if you can see my slides. Our next step with them, it's even further than that, which is this slide that I have over here. Can you guys see it or no? Okay. So in that slide, The psychiatric technicians is the current. We're actually going to have that community health workers, which are people from the community that are currently providing, they go from home to home to assess who's ill in HIV, who's pregnant. So this is what they currently do. They make sure that people are connected to HIV care, or women who are pregnant are connected to perinatal care, and that newborns and children are getting pediatric care. That's their current job. And these are people from the community that get a 6-month training to do what I just mentioned. So they don't provide medications, they just make sure that there is a follow-up and connectivity with their care, and they're supervised by people in the clinic where they belong to. So it's a network of 6 community health workers per nurse and medicine technician, and they're trained to go from home to home to do that. They get a little payment, but it's a miserable payment. It's very little. They do it because they want to contribute to the community, and we're about to train them to do psychotherapy, because there are multiple studies in Africa that have shown that community health workers, which are people from the community that probably only have an elementary school, I don't know if you call it elementary school or primary school, the first 6 years, so they know how to read and write. And they're the ones who are providing mental health care. And there are multiple studies that have shown that. So this is super doable. And I know that it sounds a little weird, but it's absolutely doable as long as they're properly trained and well supervised. So the idea is not just to tell them do this. If you train them properly, the training could be a 6-month training that doesn't require that many resources. And if it requires some resources, the comeback is amazing, because you will have a community that will be able to take care of itself with most of the depression, anxiety, and substance abuse that are taking place in the community. Did I answer my question? Your question, I'm sorry?
Okay. Dr. Wainberg?
Yes.
Yes, I am Abigail. I am a medical representative with Apotex, and I just really wanted to express our gratitude to you for your presentation today. This is on behalf of Apotex, Cari-Med, all of the pharmacists that are gathered here today. It was filled with a lot of information, useful information, the global picture of mental health and the way forward, how we can increase the access for persons suffering in this way to get help and treatment. And we really want to thank you for setting aside the time. You could be doing something, I'm sure, relaxing on this Sunday. So we really want to, again, thank you so much.
A pleasure. A pleasure. You were a great audience. You laughed at my bad jokes. You asked very, very good questions. And I hope that something good can come out of this. And let me know if I can be of any more help.